Уважаеми колеги, за мен е голяма чест да бъда модератор на тази наша следваща онлайн среща. Нашата първа среща беше на живо през март тази година, когато професор Дацерт дойде по покана на ректора на Тракийския университет професор Ярков да изнесе цикъл от няколко лекции на тема качеството на слуха и качество на живот. Сега е време да се срещнем в интернет пространството и да дадем думата на професор Дацерт да изнесе своята втора лекция, която е на тема причини за слухово увреждане и лечение, консервативно лечение на слуховата загуба. Следващата лекция, която също ще бъде онлайн, ще бъде на 4 декември, след няколко месеца, която ще е на тема хирургично лечение на слуховото увреждане. А четвъртата заключителна лекция от цикъла от тези 4 лекции ще бъде през март следващата година, когато ще се проведе и нашият оперативен курс по отохирургия. Искам да ви представя професор Дацерт. Той е директор на университетската клиника в Бохум. Има значителен опит в реконструктивната хирургия на ухото, включително кохлеарни имплантации и имплантируеми слухови системи. Той има над 600 публикации в специализирани издания, като през последните години те са повече от 300, а от началото на тази година са повече от 50. And now some words in English. Professor Dazert is an experienced otorhinolaryngologist, covers the entire spectrum of ENT care. He is director of the ENT University Clinic in Bochum, Germany, and has outstanding experience, especially in the reconstructive hair surgeries, cochlear implants, and implantable hearing devices. Professor Dazert has more than 600 publications in specialized publications, and in the last 5 years, they are more than 300 publications, and in the current year, they have more than 50 publications. Now is the second lecture of our lecture Hearing Quality is Life Quality, and the lecture is Causes of Hearing Loss and Conservative Treatment. Please, Professor Dazert, give your lecture online.
Thank you very much, dear Peter, for the kind introduction. And I also more than happy to welcome you, dear colleagues, dear friends, ladies and gentlemen. It's a great pleasure to give you the second presentation in the lecture series Hearing Quality is Life Quality. And at the beginning of the year, we have talked about how hearing works and why hearing is important for human being and for social life. Today, as Professor Roef mentioned already, we want to address a number of diseases that affect the hearing, and I will mainly focus on conservative treatments in these diseases. In the third and fourth lecture of this series, I will then speak more about the surgical indications and the surgical techniques to improve hearing. So as mentioned already, I'm from the city of Bochum, which is in the midwestern part of Germany, about 400 kilometers away from Berlin. And our university is the Ruhr University here in Bochum. This is a nice view to the campus and the Audimax. And the Ruhr University is one of the biggest universities in this area, with about close to 40,000 students, 6,500 people who work here in 21 faculties. So it's a large university, so that you know a little bit about where I am coming from and where I am working. As mentioned already, I'm the head of the Department of Otolaryngology here at the Ruhr University for a relatively long time. I was trained in Würzburg University with Professor Jan Helms, and I did a number of qualifications and trainings over my time. And since about 5 years, I'm a proud honorary member of the Bulgarian ORL Society. And this because I have a long-lasting relationship to Bulgaria and to all my Bulgarian friends and colleagues. And in particular with Professor Roev, we do every other year a surgical course for ear surgery and temporal bone preparation. And this is a very nice cooperation. And I'm happy that we now also do the scientific and university cooperation, which will be continued today. So the second lecture, causes of hearing loss and conservative treatment. These are my disclosures that should not influence the contents of the presentation. And this is the slide I finished my last talk. And those who have listened remember that hearing, in particular binaural, so bilateral hearing, is not only necessary to listen to sounds, but in particular is important to form the ability of communication. So speech communication contributes a lot to the mental and physical integrity in terms of mood control, balance control, and so on. Is an option to react to alarm sounds like in traffic or in working situations, allows us to listen to music, which is very important for some people at least. And to summarize, good hearing is the chance to participate in social life, which is necessary for all of us and should lead to a good quality of life. So today we want to look to the diseases that affect hearing, and here are different types of hearing loss are distinguished, which is the sensory neural hearing loss, which is the most common kind of hearing problem. This is, for instance, sudden sensory hearing loss or hearing loss depending on degenerating processes like in aging, noise damage, drug damage, and so on. And on the other side, we have the conductive hearing loss, which mainly is due to affections of the outer ear canal, the tympanic membrane, and the middle ear. And as you may know, there are also a combination of both, so mixed hearing loss. This may, because of genetic disorders, infections, traumatic origin. So these are the different types of hearing loss we have to look at. As I started already to explain, conductive hearing loss origin mostly we find in the outer ear, in the external ear canal, tympanic membrane, or in the area behind it, in the middle ear area. These are the ossicles. So if, for instance, you have the outer ear canal blocked by earwax, this may lead to a conductive hearing loss. Also a defect of the tympanic membrane or a dislocation or fixation of the ossicular chain may also do this. Sensory hearing loss is located in the cochlea, in the inner ear. These are the semicircular canals, and both organs form one anatomical and physiological system. And the neural hearing loss is associated with the auditory nerve. And we also differentiate central hearing loss, which affects the brain, so the central auditory pathways. We also look to talk to each other and discuss what we are doing to the degree of hearing loss. And this is interesting because a hearing loss down to 20 dB, which is a lot already, is still considered to be normal hearing. Only if the patient hears worse than 20 dB, we are considering this as a mild hearing loss. And that goes on over moderate, severe, till to a profound hearing loss when the hearing loss is more than 90 dB. People with a profound hearing loss are almost deaf, and they are usually candidates for cochlear implantation. So the graph which is used here, we also apply for hearing tests for pure tone audiograms. And as you see, here are the low frequencies, the mid frequencies, and the high frequencies. And the hearing loss in decibel, loudness in decibel, is on the x-axis here. And so a hearing test also has this orientation. Most important frequencies are between 750 and 3000 about. These are the frequencies of speech, and they are really important for speech understanding. And therefore, we have a certain look to these frequencies between 1000 and 3000 Hertz. So today, I mainly want to discuss with you diseases that affect the sensory neural hearing, like certain kinds of congenital hearing loss, sudden sensory hearing loss, which is quite common. Traumatic hearing loss may affect all types of hearing loss, but also sensory hearing loss. Noise-induced hearing loss, very important. Ototoxic affection of the inner ear. And chronic diseases that affect inner ear hearing, like presbycusis or Meniere's disease, or neoplasia like vestibular schwannoma. If you remember my last talk, the organ of Corti is the main place, the main organ for inner ear hearing perception, for sensory perception of hearing. And the organ of Corti is organized of 3 rows of outer hair cells, 1 row of inner hair cells. And this organ works for the mechanoelectrical transduction. So the stereocilia, the hair bundles on the outer hair cells, are deflected mechanically by the tectorial membrane. This is a signal to the outer hair cells to contract, so to move. And in this way, they work as the cochlear amplifier up to 60 dB. And the pre-amplified signals then stimulate the inner hair cells. And the inner hair cells, these are the main hearing cells, so to say, they make contact to the endings of the auditory nerve. And this is the area of the synapse between inner hair cells and auditory nerve. And this is important to know for the next disease I want to discuss with you. So congenital hearing, so people that are born with a hearing loss, is the first group I want to discuss a little. 50% of congenital hearing loss have a genetic origin. And in the meanwhile, we know more than 300 syndromes that are associated with hearing loss. 25% are usually caused by infectious diseases during pregnancy or during birth, like CMV, toxoplasmosis, rubella, and many more. And in 25% of congenital hearing loss, we don't know the origin, so this is idiopathic origin. We have also the last time talked about the newborn hearing screening, which is mandatory in Germany during the first days of life. And as far as I know, this is also the situation in Bulgaria. So very easily when the kids sleep, they can be tested with ABR or autoacoustic emission. And this investigation gives a pass or non-pass. And then further things can be initiated if necessary. So remember, newborn hearing screening during the first days of life. So the next very important topic I want to discuss with you is the so-called otopherline deafness, deaf and benign. This is also a congenital hearing disease and goes along with a sensory neural hearing loss due to mutations in the otopherline gene, OTOF. And this topic is so interesting because there are brand new aspects how to treat it, and that's why I included it in my talk. So here we are looking to the synapse, remember this synapse, between inner hair cell and spiral ganglion neurons. This is the inner hair cell, this is the nerve ending, and this is the synaptic gap here between those two processes. And the synapse is a so-called ribbon synapse with vesicles along the ribbon, like here, and these vesicles, they contain the neurotransmitter, which is glutamate in the inner ear. And when the inner hair cells get a stimulus, these vesicles release glutamate into the synaptic gap, and the glutamate then travels to the receptors, to the glutamate receptors, these AMPA receptors at the nerve ending, and then the nerve is stimulated and the electric pulse goes through the nerve to the brain. Otopherline, which is the subject here in this disease, is responsible that the vesicles are able to release glutamate into the synaptic gap. And if otopherline, because of a mutational problem, is not produced, the vesicles cannot release, cannot do the exocytosis of glutamate, and the information transfer from the inner hair cell to the nerve, to the hearing nerve, is not possible, which means that results in a congenital bilateral hearing loss or deafness, and about 200 individuals worldwide are affected by this disease. This is not very much, these are only a few people, but I will tell you what happened during the last years and what otologists can do nowadays. So there are several groups who were working on otopherline deafness, and to these researchers also include German colleagues like Ellen Reisinger from Tübingen or Tobias Moser from Göttingen. And they thought about a vehicle that may help to transfer the genetical information of otopherline into the cochlea and then make the cochlea, the inner hair cells, produce otopherline. And then transportation, so the synaptic transfer would be possible, and hearing, hopefully, would be possible. So the first studies were taken out in otopherline knockout mice, so OTOF minus, these are the mice. And this is the situation here. These mice were deaf, no hearing, and they didn't show auditory brainstem responses. So this group found a vehicle, and in this case, it's an adenovirus, adeno-associated virus, which is able to go into the inner ear and transport the DNA for the production of otopherline. And since otopherline DNA is a large molecule, it needed to be divided into two pieces, and these one piece each was transferred into different viruses. And the virus suspension was injected into the cochlea of the animal through the round window. And then they were waiting for some weeks. And after some weeks, otoferlin expression in the inner hair cells, these are the inner hair cells, these are the outer hair cells, could be detected by green fluorescent protein. And also, these animals seem to be able to perceive sounds. And at this time, auditory brainstem response were detectable as a sign that these animals now be able to hear. So this was a fantastic finding published in a good journal. And these results encouraged researchers to transfer these positive results into human beings. And I brought you some brand new publications from Nature Medicine and Lancet. You know, these are high quality scientific journals from this year. And the researchers present here their studies in 4 or 5 children with deaf and benign disease, so otoferlin deafness. And they applied a similar technique as I just presented. So the OTOF transgene, so the DNA information, was packed into 2 different viruses, adenoviruses. These adenoviruses, or the suspension, was injected through the round window into the cochlea and then diffused into the cochlea, into the inner hair cell, into the nucleus of the inner hair cell. And then the genetic information was put together and the inner hair cell was able to produce otoferlin. This is the theory, at least. Here you see the ribbon synapses and the nerve endings as shown in the other scheme already. So a single injection of this OTOF transgene was administered into the cochlea through the round window of 5 children. And then these are the results after a few weeks. And what the researchers saw, and the doctors who did this, that the children, first of all, were able to stand this treatment. So there were no real side effects that were present at the situation. And also, the children seemed to have some sound perception. And that was tested with ABR, so objective hearing tests, audiometric brainstem, auditory brainstem results. And the hearing is on this axis here, and the frequency is on this axis here. And this is 1 patient out of 5, right? His right ear, his left ear. And before therapy, his hearing was very bad, between 80 and 100 dB, so almost deaf. And after 6 weeks, after 13 weeks, after 26 weeks, we see the ABR results, so the hearing results are between 40 and 60 dB. So this child developed a decent hearing, also in ISSR, which also is an objective measurement for hearing, objective hearing test. And all the other kids reacted in the same way. So that was a kind of sensation that a genetic disorder could be treated with gene therapy in this way. This is just the very beginning in this field, and it's one very precise disease, and only a few people in the whole world will have benefit from this. But hopefully for the future, this kind of therapy will be applicable also to other genetic diseases. Those people who have not the otoferlin disease can be only treated with hearing aids, and this needs to be done very early, so right after birth. And this will be done by the pediatric audiologist. So he is also able to test whether the young babies during the first weeks and months of their life will have benefit of the hearing aid. If that is the case, it's fine, we continue. If they don't have a good result from the hearing aid, they are candidates for early cochlear implantation, and that should be done during the first year of life. So if the baby needs a cochlear implant, it should get it very soon at month 9, 10, 11, 12 to be successful for life. Next topic I want to talk to you is sudden sensory neural hearing loss. Very common, about 30 candidates per 100,000 inhabitants will suffer from this. And this is a hearing loss of 30 dB or more over at least 3 connected audiometric frequencies that develop over 3 days or less. So it's an acute disease and may be associated with vertigo and tinnitus. So what we do for diagnosis in these cases, or the people present and they tell you, doctor, I cannot hear on my left ear, for instance. And then we check. Outer ear canal, tympanic membrane are usually intact without infection. And then we do audiometric testing, a pure tone audiometry, and sometimes even more investigations. We also look for the balance. We may do some blood tests, and we do some radiologic imaging. In the pure tone audiometry, we usually find a sensory hearing loss of 30 dB as more. And why is it necessary to give radiologic investigations to these patients? Because we know today that a patient with a sudden sensory neural hearing loss has vestibular schwannoma in about 5%. So 5 people out of 100 with a hearing loss suffer from an acoustic neuroma. And these are pictures, MRI pictures. This is the neuroma. You see inside the internal auditory canal. This is the cochlea in the T2 weight. And this is the vestibular organ. Internal canal is filled with the tumor. And if we put gadolinium contrast mode in addition, we see the tumor here. We see it inside the internal auditory canal. It may be also present in the cochlea and in the vestibular area. So acoustic neuroma or vestibular schwannoma is obviously much more common than we thought in the past. And we also look to the cause classification 1 to 4. And this depends whether the tumor comes out of the internal auditory canal into the cerebropontine angle, whether it touches the brain and the cerebellum, or whether it impresses the brainstem and the cerebellum. So this is a topic for one of the next lessons, but I wanted to mention that every patient who suffers from a sudden sensory hearing loss needs an MRI to exclude vestibular schwannoma. For many decades, the standard therapy was high-dose steroids IV. So for instance, 250 milligram prednisolone IV for 3 days, and then a reduction of the dose of prednisolone over 10 days. What is new in this field was investigated by this study, the so-called HODOCORT study, which stands for high-dose corticosteroids. This is a multi-center study which took place in Germany during the last 5 years, and more than 300 patients with sudden sensory hearing loss were included. And the aim of this study was to test high-dose systemic glucocorticoid therapy versus a low-dose treatment of 60 milligram prednisolone. And the interesting finding of this study was that the high-dose steroid treatment was not superior to a lower dose treatment in these patients, but was associated with a higher risk of side effects. So after many, many years of treatment, the hearing loss with high doses of steroids, we now change in Germany to a new standard, which is prednisolone 60 milligrams for a couple of days, and then temper it out, reduce the concentration. Another option is to apply the steroids intratympanic with a very fine, thin needle through the tympanic membrane. You may give antibiotics if necessary, and patients need to be advised to avoid ototoxic drugs. If all this doesn't help, patients may be candidates for hearing aids, or if their hearing is worse, for cochlear implants. Just a short word on ototoxic drugs. So if you have a patient with a damaged hearing or who is sensitive for a hearing loss or had it in the past, try not to give him aminoglycoside antibiotics, try to give other antibiotics. Platinum-based chemotherapy also aims for the inner ear. This may be necessary for head and neck tumor treatment. Then it's superior to the ear, so you have to give it, but do hearing tests in these patients, follow the hearing over time. Loop diuretics are also going towards the inner ear. Salicylates like aspirin, so pain reliever, try not to give aspirin to patients who have inner ear problems. And also malaria therapeutics and many others are known to affect the inner ear. Just to keep in mind that there are certain drugs that should be avoided if possible. Next disease, which is common and interesting, is noise-induced hearing loss. So this may be caused by professional or leisure time noise, may occur immediate or over a longer time, for instance, in professional exposure. It may affect one ear or even both ears, and it may be temporary or a permanent situation. So what you should keep in mind is that noise below 70 dB is unlike to cause noise-induced hearing loss. So sounds below 70 dB are, so to say, safe. Long or repeated exposure over 80 or 85 dB is dangerous for the inner ear and may cause hearing loss. And the louder the sound, the shorter the time to provoke noise-induced hearing loss. If you look at this scheme here, you see here in the middle the limit, the dangerous limit of 80 dB. If you are below this, you are safe. And when we talk to each other, TV, etc., this is about 60 dB. When you walk on the pedestrian way and a truck is coming by, this is about 80 dB. This is relatively loud. But look at this. If you go to a nightclub and the night is going on, the loudness may be 100 dB. So this is 20 dB above the dangerous border, so to say. So your damage so your ear may be damaged already by this. And sometimes when you come home from the nightclub or from a party, you hear some ringing in your ears or you feel a pressure in your ears. And these are the first signs that your ear may have a temporary damage. And if you go to a rock concert, it may be even louder, 120 dB, which is almost like machines in roadbreaker work. So these are dangerous pressure scales, and you should keep this in mind. And if you are sensible to this, plug your ears when you go to a rock concert or when you go to a party. So just to show you a little bit the scale of sound pressure exposure for people. So this is a typical audiogram from a patient with a noise-induced hearing loss. Usually frequencies around 4000 Hertz are affected like this. And if you listen to a tinnitus in this case, usually you find the tinnitus also in this frequency range. These are pictures from raster electron microscopy, scanning electron microscopy. These are normal human inner ear situations, 3 rows of outer hair cells. These are the stereocilia. They are all intact, usually V-shaped here. And these are the inner hair cells with their stereocilia bundle. And this is the cochlea. These are animal subjects here, and they are exposed to noise, and the outer hair cells are dyed and damaged, and you can imagine that this animal does not hear anymore. And the important thing is that damaged hair cells in mammals are not regenerate. So if they are dead, they are done. So there's not much to do about it, and therefore it's very important to protect your ears. Know what noise degree can cause damage to your ear. Remember the decibel scale. Protect your ears with earplugs, and if that not is possible, try to get far away from the noise exposure. So keep distance. Protect yourself and your children with the 60-60 rule. You may remember this from my last talk. And move away from noise. I mentioned that already. And if you think you have a hearing impairment, go to a doctor and get a hearing test. This is a picture from my last talk with the 60-60 rule. Children and also adults should be limited to no more than 60 minutes of audio devices a day at no more than 60% of the maximum volume of the radio or of the recorder you are using or your smartphone. So the 60-60 rule is important to know, and you should also spread this under your friends and your family to prevent from noise-induced hearing loss. I also want to shortly refer to age-related hearing loss, presbycusis. This is a very common disease in mid-European communities like in Europe, where we live. And in the future, because of the demographic development, we will be confronted with this even more. So people getting older and older, and we have more people with presbycusis. It usually starts during midlife. So people that are 60 plus should look at this, or their doctors should be aware. In the beginning, it affects the high frequencies because of the degeneration of the outer hair cells. It impairs this speech discrimination in noise. So if you go to a restaurant or to a cafe and you don't have the high frequencies anymore, you have problems to listen to the communication. And this is the first sign of presbycusis in many times. This may lead to social retraction. You don't like to go out with your friends. And as the scientific investigations show, it may also support the development of depression and even affecting dementia, and the development of dementia is discussed at the moment now. In this relationship, I would like to present you this information from the Lancet Commission. Lancet is a high prestigious scientific journal, as you know. And the Lancet group, they present non-modifiable risk factors for dementia. This is this. And modifiable risk factors for dementia. And if you look here, hearing loss in midlife is a modifiable risk factor for dementia. So obviously, if we cure people from hearing loss in midlife, for instance, give them hearing aids or give them cochlear implants or whatever they need, the risk to get dementia later on is reduced by 8%. And this is a very important information, I think, to check patients in the 50s and 60s. So ask them whether they have hearing problems, whether they can stand everything, in particular in noise, whether the family complains about that TV is too loud and things like this. So hearing loss in midlife obviously is a modifiable risk factor for dementia, and we should keep that in mind for our patients. This is what I mentioned earlier, that the development is in a way today we have about 11% of the worldwide population is older than 60s, but in 2050 the data estimate that 22% of the population, the worldwide population, is older than 60. And so these people have a chance to get all the diseases they wouldn't have reached when they would have died earlier. And we also know that people above 65 in 30% suffer from a hearing loss. And people that are older than 80 years, 55% suffer from a hearing loss. So all this should make us really aware that we treat not only the heart diseases and cancer diseases, but also check for hearing and, if necessary, give them an adequate treatment. Why is hearing so important for elderly people? We have discussed this also already. Hearing is the precondition of verbal communication in profession, family, and leisure time. And particular in older patients, it promotes social integration. So if they are possible to communicate with their mates, with their family, with their children and grandchildren, that makes them happy, prevents from depression, and obviously also in a little bit prevention for dementia. It stimulates cognitive processes, so their brain gets more functional, gets more active, and it stimulates their quality of life. And this is proven by scientific investigations. So look for the hearing, and in particular in elderly and old patients, don't forget about this. Presbycusis usually can be only treated with adequate fitting of hearing aids, and this needs to be done on both ears. Also an important information, not only one ear, but both ears need to be treated and need to be fitted, and if available, also give him additional devices such microphone or a connection between smartphone and hearing aid, or between TV and hearing aid. There are very interesting things available to give people a better hearing, and this is very important. If hearing aids are not sufficient enough, those patients can be also treated with implantable hearing devices such as active middle ear implants, bone conduction implants, or cochlear implants. Brainstem implants are relatively rare. We will speak about this group of hearing devices in one of the next talks. Just a few words to Meniere's disease. This is a chronic inner ear disease that is characterized by recurrent vertigo episodes. It also goes along with hearing loss and with tinnitus. So these three, this is the trias of morbus Meniere: vertigo, hearing loss, and tinnitus. And usually this occurs in episodes typically between 20 minutes and a few hours. And the symptoms are believed to occur as a result of increased fluid buildup, which is called endolymphatic hydrops, inside the inner ear. Usually this disease starts between an age of 40 and 60 years and is thought to be a lifelong disease, so it's a non-curable disease. Remember that if a patient shows up with these symptoms, you also have to exclude migraine, vestibular migraine, or a stroke, a little stroke, a transient ischemic attack. The typical audiogram from a patient with Meniere's disease, in this case on his right ear, is a low frequency hearing loss. See, usually hearing is in this area. This patient has a low frequency hearing loss, which is typical for Meniere's disease. And for a couple of years, special MRI sequences plus gadolinium are available where endolymphatic eye drops can be detected inside the inner ear. And what you see here is this is the internal auditory canal. This is the cochlea. This is the vestibular system, so semicircular canals. And the gadolinium goes into the perilymphatic space. These are the white areas. And the endolymphatic area, there is no gadolinium. And this is black, and you see the little balls. It looks like a Christmas tree, and the balls are the black areas without the gadolinium. So this is the typical view of a cochlea with endolymphatic eye drops. Endolymphatic eye drops does not necessarily mean the patient has Meniere's disease, but is another little stone in the mosaic. So MRI with gadolinium in this special condition may be used as a diagnostic tool. As mentioned, Meniere's disease is not curable, but there are many treatments that can ease the patient's life, can improve the symptoms, and can improve life quality for these patients. So when they come with an acute episode, with an attack, we usually give medications that help with nausea, like dimenhydrinate, Vomex is the German drug for this. You also apply this for travel dizziness, for instance, dimenhydrinate. We recommend these patients a low-salt diet. You may give them diuretics or beta-histine in an increasing dosage like this, and also corticosteroids IV or also transthympanic are discussed. Injections into the middle ear, so this is the transthympanic application of steroids or other drugs, and surgical procedures I will discuss during the next lecture. But I just wanted to give you the information that Meniere's disease can be treated. It cannot be cured, but we can help the patient to have a good quality of life with this disease. So at the end of my talk, I want to emphasize that all treatments we do for hearing loss aim for the best possible hearing in our patients, providing a good ability of communication, provide a stable mental and physical situation of the patients. And the most important thing is that people with hearing loss still like to be together with other people. So social integration is the most important thing in our life, and this is what makes us happy. And again, I want to emphasize on the topic of this lecture series, hearing quality is life quality. And here I'm at the end of my talk, and if you have questions, I'm more than happy to discuss with you. Thank you very much for your attention.
Thank you, Stefan. Thank you, Professor Dazert, for this very interesting lecture and to the overview of the possibilities of hearing loss. Колеги, ако имате някакви въпроси към професор Дацерт, може да натиснете.
So you mentioned that we have to have like a specific diet, like lower salt, when you were talking about male disease. how does diet affect our hearing?
Well, the low salt diet is expected that not too much fluids will go into the body, and this is expected to reduce the endolymphatic hydrops. You know, we don't know exactly why the hydrops is generated. Is it an overproduction of endolymph, or is it maybe reduced resorption of endolymph? But the low salt diet and also not too much coffee, not too much alcohol, these are the recommendations. They should reduce the endolymphatic hydrops and therefore reduce the number of the Meniere's attacks and the symptoms of the patients. And the same intention is with the diuretics. They are also thought to, get water out of the body and reduce the endolymphatic hydrops. Does this answer your question?
Yes, but also, are you saying that a person's weight can have something to do with maybe their hearing loss later on in life?
Well, overweight is not a primary cause of hearing loss, but the low salt diet is in particular for patients with Meniere's disease, not with hearing loss. If you have a sudden sensory hearing loss, in general, you should not eat too much salt, of course. But the low salt diet is a recommendation for patients with endolymphatic hydrops and Meniere's disease.
Thank you.
You're welcome.
Another question?
Hello, Professor Dazert. I'm Venelin Marino from Bulgaria. I would like to ask you what kind of corticosteroids you use transtympanically for treating sensory neurohearing loss.
We also use prednisolone, and I cannot tell you the dose exactly right now. I have to look it up. But we put it with a fine needle through the tympanic membrane, and then you can see how the tympanic space, the cavity, fills up with the prednisolone. And then we have the patient rest for 15 minutes, and he should not swallow during this time, that the drugs stay inside the middle ear. And after that, this time is obviously enough that the prednisolone, the steroids, can move through the round window and through the oval window into the inner ear.
Thank you so much for your answer.
Welcome.
Another questions for the audience or for the colleagues online? We have here another question. This is, does COVID infection cause deafness, and what could be the prevention for the COVID infection and hearing loss?
Prevention for COVID infection?
For hearing loss after COVID infection.
Oh, that's a difficult question. I think the best prevention for COVID is to get a vaccination, of course. And in Germany, it's still recommended to do the vaccination at a certain time. Hearing loss associated with COVID cannot be treated in a causal therapy. So we would give these patients also glucosteroid treatment, like in sudden sensory hearing loss, and then see how they get along with this. But no special treatment for hearing loss associated with COVID.
The question was that the colleague mean that the therapy during the illness It's especially treatment the COVID that can be prevent the hearing loss after COVID infection.
Or the question is, when you have COVID, how can you prevent hearing loss?
Yes, yes.
No special treatment is known to me to prevent this. Usually, if people have severe COVID symptoms, they have other problems, but I would, avoid like ototoxic drugs. So in terms of antibiotics and pain medication and loop diuretics, things like this. But otherwise, no prevention is known to me.
Another questions from the audience? We have only 3 minutes to the end of our session. More questions? When we don't have, I want to say thank you, Professor Dazert, for your lecture and for your kind information about the hearing loss and about the causes of the hearing loss. And we close this session now, and we stay in contact to the next session that will be in the beginning of December.
Mm-hmm.
Yeah, Stefan?
Thank you very much. It was a great pleasure to do this. And I'm looking forward to our next meeting. And I wish you all a very nice afternoon and evening.
Всичко хубаво, колеги. Благодарим за вниманието. Thank you very much again, Stefan. Bye.
Bye-bye.